Gotcha. All right. Well, appreciate that. Again, my name is Dr. Erik Gentry for those who haven't met me. And obviously, we're going to be kind of discussing kind of the role of biomarkers and kind of helping with some of these diagnoses. I have no conflicts of interest to disclose. Here's the CME code for those that need that. Again, we'll have that kind of throughout the presentation as well. Here's kind of a brief roadmap of the order of things that we'd like to discuss. Kind of start off with a background of Alzheimer's disease, review some of the biomarker, what they are, what we can use them for, a brief clinical case, a timeline of the development of some of these markers, kind of review some of the mimics of Alzheimer's disease, and a few multiple choice questions at the end. Here are our learning objectives. Again, just to kind of review the ATN framework of these biomarkers, ways that we can use these biomarkers to differentiate AD from common cognitive mimics, as well as how we can use those to develop, kind of help guide our diagnosis and our management of disease in the future. Okay, so why biomarkers matter in 2026? So obviously we have an improved diagnostic accuracy. Um, there's an idea that maybe we'll be able to pick up asymptomatic patients, maybe patients with mild cognitive improvement, cognitive impairment in the future, and either slow the progression to Alzheimer's disease or maybe even stop that. It also is important the role and selection for patients for anti-amyloid therapy, some of these monoclonal antibodies. If they don't have any amyloid plaques, then they would be a poor candidate to possibly try to clear these plaques. It also is important maybe to look at as the disease progresses, an idea if they're having a response to the therapy as well. It's kind of a brief slide kind of summarizing Alzheimer's disease. Obviously, it's the leading cause of dementia. It affects over 7 million people in the US as of last year. Another important thing that to kind of think about is that the cases have continued to expected to double every 20 to 30 years, which is going to be a huge number as the population continues. It accounts for about 60-70% of dementia cases, and it has a huge burden of healthcare costs, both in terms of patient care as well as some of those caregivers are not able to fulfill other duties. And so overall, that burden exceeds greater than $300 billion. Again, we believe that the pathophysiology begins decades before they first show signs of symptoms, and it creates this long kind of preclinical phase. We'll kind of discuss that a little bit more on the next slide as well. That's something that we want to try to take a look at as well. And this is kind of relieving this reality that we're diagnosing AD too late in the disease process. Is there anything that we could do to maybe kind of one diagnosis this earlier? Maybe try to help counsel the patient and the patient's family on what to expect moving forward, or maybe even have some sort of interventions. I also really like this drawing. So where my mouse is, I apologize. This drawing here is actually done by Dr. Alzheimer's himself. So I thought it was kind of interesting to kind of see these first drawings of some neurofibrillary tangles. All right, this is a great slide. Again, that's kind of highlighting that we have this period of 10 to 20 years before that we're showing signs of symptoms where we're having this decreased clearance of amyloid leading to the accumulation of these amyloid beta plaques, which then in turn leads to this amyloid beta cascade to these neurofibrillary tangles, which ultimately we believe are causing this neurodegenerative effect. So as we can see, it's possible maybe we could have some sort of biomarkers here, the CSF and tau, or other things that maybe we should take a look at finding signs and symptoms before that we're seeing any sort of behavioral change. That may be a possible area for intervention in the future. Obviously, this is kind of all down the line, but that's something that we want to kind of think about as well. So again, it's kind of highlighting a patient without AD is going to have this decreased clearance of amyloid leading to the accumulation of these plaques, these tangles, ultimately leading to this cognitive impairment that we see here. This is again kind of highlighting that, but it's pulling out some of these potential biomarkers that we can take a look at, the accumulation of amyloid beta. Here we also can show some synaptic dysfunction. You can see that either on a functional MRI or DG PET, as well as some changes in tau. So this is kind of showing that we expect that there could be some changes before the patients are even showing symptoms, as well as leading to mild cognitive impairment and ultimately dementia. So at this point, you want to think about, just from a purely clinical diagnosis, it's still very important to have a great uh, natural history examination as well as some cognitive testing, and that can be up to 70 to 80% sensitive. So it's still a good idea to try to do those things and kind of points us in the direction of what we think might be going on. At the same time, there's also a lot of common mimics that might present similar to Alzheimer's. So those include Lewy body dementia, FTD, vascular dementia. Oftentimes, in a younger patient, we might kind of consider pseudodementia or depression. Medication effects. So you also want to always try to review all the medication that they're taking. Could these be contributing as well? Again, the clinical phenotype doesn't always equal the underlying biology. That's why these biomarkers become important. And especially in America, we think mixed pathology is very common, particularly with vascular disease and vascular dementia being very common. Biomarkers are essential. Again, as we kind of mentioned, over time we've kind of shifted from this clinical diagnosis more to looking at the biologic definition as well, and they allow us to be even more accurate in our diagnoses. We can confirm that there's both amyloid and tau, which is necessary for the diagnosis of Alzheimer's disease. Also, as kind of mentioned, maybe we'll be able to pick up some preclinical disease, trying to show that more and more of these markers are elevated at an earlier stage before they even show signs of cognitive change. Again, ultimately, the goal is, could this be a way to identify patients that might benefit from disease-modifying agents earlier? Again, this is all kind of theoretical and looking more towards the future, but that's ultimately where we'd like to try to take this. So first, I want to kind of start off with a clinical case, and I apologize for just a slide of words, but I think it's important to kind of look at, as you're seeing a patient, you have all this information that's kind of given to you, and how do we kind of sort through this information? What's important? What's not important? I just kind of want to briefly summarize here. You guys obviously can read this for yourself, but so one, we have the patient's age, we have the patient's profession. That kind of gives us an idea of maybe their level of education. We also can see maybe some past medical history as well, which kind of maybe we could point to some other disease processes, and kind of exactly what symptoms or what brought the patient in to be evaluated. That can be helpful as well, kind of point you to maybe what fields of memory they're having some changes in. And then also we get thrown in at the end a little bonus that they were kind of evaluating some of these typical things that maybe a primary care physician or your fellow general neurologist might take a look at as well. TSH and B12 were normal. So again, I just kind of pulled out some of these information. So the age is important. If they're younger than 65, maybe you could consider an atypical presentation or even pseudodementia, as kind of alluded to earlier. Education level, I think that's important to note where they're at. Sometimes that can have some changes as well. Past medical history, hypertension, hyperlipidemia. Maybe they're at risk for vascular disease. Maybe we think vascular dementia as well could be playing a role. How long have they been having the memory issues? That can be helpful as well. So if you go back to some of those previous slides, maybe they're having an accumulation of pathology for the past 10, 20 years, and they're just now showing symptoms for the past year. What type of memory issues were they having? Are they having ability to recall specific episodes, but they're not able to do things that they mentioned, cooking elaborate dishes. Sometimes you'll have a patient that comes in, that they saw their mom or dad at Thanksgiving and they weren't able to make that pumpkin pie quite the way that they used to. That might be a sign of normal aging, but maybe there's some other things that might come to your attention. So based on that, what steps would you guys take next? Yeah, yeah. So, Dr. Freeland mentioned kind of the next step. So we just did a mini mental status exam. So next we would want to kind of have more comprehensive testing. Great. Yeah, yes. So Dr. Nifedov, he wants to even go further with some of the reversible things. I know we just kind of briefly mentioned B12, TSH, but there's some other things we might want to look at as well, for sure, definitely. Yeah. So Definitely agree that some further testing is important as well as maybe getting an MRI. This particular one showed that she had this global atrophy, kind of noticed some paraventricular and subcortical hyperintensities as well. You know, at that point, diagnosed with mild cognitive impairment, presumably secondary to Alzheimer's disease. We kind of continued with some additional cognitive testing, as that Dr. Freeland mentioned, and the MMSE continued to decline, which caused them to get some further imaging, including this amyloid PET scan confirming decreased or increased cortical uptake, suggesting moderate to severe burden of these amyloid plaques. All right, so we're kind of talking about biomarkers, but kind of in general, are there any other diseases across medicine that you guys are aware of biomarkers for and what that might be used for? Yeah, yeah. So cancer is a great one. Sometimes different cancer biomarkers can help us guide treatment. I'll kind of show some examples of that on the next slide as well, or I guess the two slides. But they're objective measures of biological characteristics that reflect normal processes, as well as pathogenic processes or responses to therapeutic interventions. As Dr. Johnson mentioned, sometimes different cancer biomarkers can kind of help guide our treatment options. So again, diagnostic markers identify presence of disease. I wanted to, I made an effort to picture troponin for acute myocardial infarction because there's also other reasons. Yes, sir. Yes, sir. Yeah. Correct. Yes. Yes. So, correct. Correct. So yeah, so Dr. Brown made the point to add that ideally this is the perfect world for biomarkers. Again, as we kind of see on the next slide, there are limitations with biomarkers as well. We'll discuss that kind of moving forward. But as I kind of mentioned, with this diagnostic biomarker, or even troponin, it can be elevated in acute myocardial infarction, but it can be have other causes that could cause it to be elevated as well. That would kind of limit its utility. Um, I want to kind of compare that with CSF phosphorylated tau and Alzheimer's disease as well. We additionally have predictive biomarkers which can predict response-specific therapy. As Dr. Johnson kind of alluded to, we have different biomarkers in cancer that can predict response to different therapeutic agents like this monoclonal antibody here. Amyloid positivity can also predict eligibility for these anti-amyloid therapies that we're starting to develop. And so now we want to kind of discuss some of the evolution of the AD diagnosis from this clinical definition to kind of incorporating some of these biomarkers. And obviously, as we kind of mentioned, a perfect world, there are some limitations to those biomarkers as well. So in 1906, Alzheimer's first described Alzheimer's disease with the help of some Italian neuropathologists as well. And so first, we kind of noticed this diffuse global atrophy that we're seeing here, as well as some changes in the ventricle size, as well as some changes in the hippocampus here, as well as this aggregation of amyloid beta into plaques, as well as neurofibrillary tangles here. And one of the important things here was that diagnosis was only possible at autopsy to be completely sure. Obviously, they had some ideas and thoughts from 1906 to the next time point. That's exactly what we needed was the biopsy itself. Here we have one of the most poorly named institutes I've ever heard, the National Institute for Neurological and Communicative Diseases and Stroke, Alzheimer's disease related, Alzheimer's disease and related disorders association, the clinical criteria. Um, I'm thinking they were probably getting paid by the letter when they were naming their organization. But essentially at this point, we had kind of three categories of Alzheimer's disease. You had definite, which would require either a biopsy or an autopsy to have this histopathological markers again, amyloid beta plaques or tau, neurofibrillary tangles. Probable AD, which basically would be confirmed dementia, as well as one other area of impairment, either language, perceptual skills, attention, constructive abilities, orientation. Um, they had to be the right age, 40 to 90, and there couldn't be better explained by another cause. And then we also had possible AD, which you'd think that the vast majority of patients would have fallen to because now, as we know more about neurology, there can be a lot more mimics and other things that could have some changes as well. And that would be a patient with an atypical onset of presentation and something else that might explain their changes. All right, in the 90s, we had structural MRIs became more routine. We're able to see some changes in hippocampus as well as global atrophy. But again, it's not very specific. And some of this atrophy shows up later in disease progression. So that was one of the big limiting factors for that. But at the same time, it's a step forward rather than having to wait until death to see some of these signs of any of these changes. In the early 2000s, we had FTG PET enter the clinical use, and this was another great tool for us. This image is particularly important, especially those of us who just took rat exam. Sometimes they'll just show us a FTG PET and ask, hey, what do we think is going on in terms of disease? Um, Particularly with AD, it's going to show this classic temporal parietal hypometabolism, as you can kind of see here. Um, this is particularly useful whenever you're confused between two different disease pathologies. Could this be AD? Could this be, some other uh, things that we're thinking about as well? Maybe some of these primary progressive aphasias that sometimes can be very difficult to kind of tease out, especially with ones that have very similar biomarkers as well. We'll kind of discuss that a little bit later. All right, so let's kind of discuss a little bit more about this FTG PET. What is this kind of used for? It's measuring the cerebral global metabolism, as you kind of talked about, which is essentially showing the level of activity between these synapses. Is what we kind of use it for. Again, there's certain characteristic patterns that are important for us to know. Most particularly in AD, it's going to kind of start off in the posterior cingulate, then goes to the precuneus, and eventually the temporoparietal cortex is kind of that classic thing that you see. FTD obviously is going to be the frontal and anterior temporal lobes are going to be affected. Lewy body dementia, it's going to be the back, that occipital hypometabolism. And it makes sense when you kind of think about, these patients might have some visual hallucinations. So that's kind of easy way to kind of remember that one. Clinical role. It helps kind of help support differential diagnosis when the phenotype is unclear. Again, I kind of mentioned, this can be particularly helpful whenever you're in between two different diagnoses. And as we'll kind of allude to earlier in the learning objectives, this ATN framework, this would kind of fall along with the end of the neurodegeneration, which is kind of would make sense if you're having decreased metabolism. We're able to see decreased synaptic activity, which would kind of all kind of fall in line. It does not directly measure amyloid or tau, so obviously there's some limitations there. We needed to kind of continue to expand, our biomarkers and our diagnostic capabilities. Kind of did next. It can be affected by comorbidities. It's probably less likely, but if you had vascular disease or a stroke affecting certain brain regions, it might look similar to a patient that's affected by some of these as well. Okay. Which brings us to the first amyloid PET imaging. So this is again kind of looking for accumulation of these amyloid beta plaques. This was done by a group in Pittsburgh, hence the name Pittsburgh Compound B. And this is thioflavin T, and also known as PID. And it's used to visualize where these plaques are kind of in vivo patient for the first time. At first, this was research only. But we've also kind of developed some new radio tracers that have longer half-lives that are a little bit more useful. This is what I was kind of alluding to earlier. Some of these radio tracers you might be a little bit more familiar with. Florbetapir is one that's going to be more commonly. We're often able to look for these accumulation of plaques prior to these cognitive symptoms starting, kind of going back to some of those earlier slides that we had earlier. Um, Again, this is a binary read. It's either positive or negative, and some of these cutoff points are set based on epidemiology about what designates AD versus non-AD. The high concordance with autopsy finding, meaning that afterwards they performed autopsies and they're able to confirm that there was a matchup where these scans were thinking there were plaques versus where there were plaques. Again, it's particularly useful in these earlier patients or patients that may or may not have some other concerning pathologies. And One incredibly important thing is a negative scan effectively rules out AD as the cause of dementia at that point. Not to say that they won't eventually go on to develop dementia from AD, but at that point, you're in the clear. It doesn't indicate symptom severity, meaning that the burden of amyloid plaques doesn't necessarily correlate to how demented a patient is, which provides evidence against the amyloid cascade hypothesis, but also something that is an area for future research as well. Some cognitively normal patients will eventually accumulate amyloid as well without showing any cognitive signs. It kind of prompts a lot of questions. What is the purpose of amyloid? Does it have a non-pathogenic process as well? So that's another area for future research as well. This date I thought was kind of wild. So it wasn't until the 2010s and 2012s that they kind of became more standardized to use a lumbar puncture to kind of look at these levels of amyloid beta 42 species as well as both total tau and phosphorylated tau via lumbar puncture. It seems like something that we do relatively routinely is obtain lumbar punctures, the ability to kind of have an idea of what exactly is going on in terms of dementia process is highly valuable development. Obviously, here's kind of showing that nice curved spine, kind of help open up those facets where we can obtain this. So what markers are we looking for exactly? So amyloid beta should be reduced in CSF due to this idea that it's kind of sticking in these plaques and it's in the brain. We also can look at the ratio of amyloid beta 42 to 40, and this kind of helps tease out some of the differences between individuals and kind of point more towards improved diagnostic accuracy versus amyloid beta 42 alone. Tau markers, another thing is important as well. Again, kind of going back to my earlier point of using troponin as a biomarker or even 1433, these aren't necessarily specific to a disease process. It can be elevated in any sort of neuronal injury, which kind of would reduce its specificity. And phosphorylated tau is more specific for amyloid AD-related tau pathology. And we'll kind of discuss a little bit more about these two different numbers, 181 versus 217. You guys probably seen some tests. How do I decide which one to use, which one's better? But again, this is what we want to remember. Amyloid beta should be decreased as well as the ratio, and phosphorylated tau and total tau should be increased. So, what are some pros and cons of these CSF biomarkers? So, at this point, most neurologists, or all neurologists, should be able to perform a lumbar puncture. Should have this ability to kind of help easily obtain the CSF and detect disease even before they're showing any sort of cognitive sign. It's been widely incorporated into research in specialty memory clinics. Uh, if there's any sort of kind of question, you can also kind of fall back on some of these additional imaging, notably the amyloid and tau PET. But oftentimes it's difficult to have a patient have these things performed. They kind of require specialized centers that are able to have that done. Lumbar puncture isn't somewhat invasive. We do them so frequently that we typically try to diminish the risk, but oftentimes patients perceive, hey, I'm not having a needle stuck in my back no matter what. I'd rather go in a tube or have some imaging performed, something like that. The tube type, meaning even the type of plastic that you're kind of obtaining some of these amyloid in can be changed versus if it's soft or hard plastic, which could have some changes in your reliability of information. Obviously, sometimes we obtain these labs and you send them off in the lab and you hope they're stored properly and they're being evaluated properly, but it's difficult for us to say exactly what's going on. This slide is particularly important because it will kind of begin to develop this ATN framework was introduced by Dr. Clifford Jack at Mayo Institute. He's actually a neuroradiologist. That was kind of interesting, kind of going back to Dr. Alzheimer's days as being more like a neuropathologist and kind of looking at things from a different approach. Again, you have your amyloid, your tau, and your neurodegeneration. It's just a simple plus or minus. Kind of shifting from this clinical diagnosis to having more of a biological pathway to kind of understand some pathology behind that. And whenever he in this paper, he kind of lays it out. He wants to kind of establish this as like a tool that can be used not just for AD, but maybe even other disease processes as well. Even this idea that, so many people are tied to this amyloid, maybe it could be more related to tau. So essentially wanted to kind of create a tool that can be used across time and across different modalities. That's why I had this particular kind of quote here in the paper that I wanted to kind of pull out as well. It looks like this slide cut off. So this is the National Institute of Aging Alzheimer's Association Research Framework, which was kind of based on this previous ATN paper. Again, kind of showing that you need to show that there's presence of amyloid via an amyloid PET or CSF, a tau biomarker, again, via a lumbar puncture showing tau in the CSF or the tau PET, as well as some sort of neurodegeneration biomarkers, whether that be FTG PET or some sort of structural MRI or CSF total tau. Again, each category is binary with a positive or negative based on these validated biomarkers. Again, you might notice that, hey, there's two different markers here. Let's say they get both of these, and there's some conflicting results. It wouldn't get a plus or a minus; it would just get a C for conflicting. And if they haven't had something performed yet, or that's still in the process, they would get a U for uncertain or unknown. Again, this is showing a patient, A, C, and E are showing a patient with AD. B is an age match control. This is kind of showing the first is it's going to show us the FTG PET. So it's showing that there's reduced uptake here. And then here we're showing this accumulation of the tau. Or sorry, not tau, actually amyloid beta here, which is contrasted with a healthy control. Okay, so at this point, we have the plasma biomarkers are starting to mature, essentially meaning using serum. Um, Specifically, plasma phosphorylated tau 181 and phosphorylated tau 217 are showing high diagnostic accuracy, becoming easier just to send a patient to a Quest or some sort of lab center, have some blood drawn. And it's kind of moving away from these invasive lumbar punctures that patients might be apprehensive to have done, as well as having a scalable triage model. So, you can do this a lot like more easily rather than having to perform your own lumbar punctures on all your patients. Kind of mentioned earlier, what is the difference between tau 181 and 217? So if you had to pick, kind of quick takeaway point is that 217 is more specific for AD pathology. It's better able to pick up AD patients from non-AD dementias and has closer correlation with tau PET burden. So again, if you had to pick, I definitely would lean towards 217. So in 2023, we have some clinical implementation expands as well as some approval for some of these monoclonal antibodies to gain traditional approval from the FDA, as well as these plasma assays that are having greater clinical role as well. So Medicare, Medicaid, and insurance payers are going to require biomarker confirmation before you do some of these therapies. So it becomes more and more important to make sure that we're documenting these biomarkers. Again, we obviously want to start with this clinical suspicion. As Dr. Friedland mentioned, you want to have as much testing as possible in terms of memory, that we can kind of have an idea of where exactly some of these deficits are. Then we want to kind of move to some either a blood biomarker screening or a lumbar puncture here, as well as maybe some confirmatory PET testing. And that will ultimately give us an idea of whether this patient would be appropriate or not appropriate, along with some counseling of the patient and their family. All right, this is another one of kind of the big kind of interesting developments that we recently have is this Lumipulse G. But what exactly is it? So it's kind of similar to ELISA, but a little different. So it's using a chemiluminescent enzyme immunoassay. They have this kind of this freestanding device here that's able to use serum or blood to look for this ratio of phosphorylated tau over amyloid beta 42. And it's kind of one of the next steps forward. Here's kind of a brief chart kind of showing, we have AD here. Obviously, they should be positive both for amyloid and tau. and what the pattern of neurodegeneration is. Um, Contrast that with frontotemporal dementia. They should be negative on amyloid. They should have normal or slightly increased tau. Again, we said phosphorylated tau is a better marker for AD over total tau, but there could be some increase there. Frontal or anterior parietal neurodegeneration would be seen on MRI or more likely PET scans, FTG PET. Then we have dementia with Lewy bodies, plus or minus amyloid, maybe even a mild increase of p-tau. And again, the occipital hypometabolism is going to be the predominant thing there. But with vascular disease, they should be negative for amyloid. Tau should be normal. And it says subcortical, but it could also be kind of variable depending on their vascular insult. Again, kind of talked about these mimics. These are some of the ones that we want to kind of look at as well. So primary progressive aphasia or PPA variants versus AD. So these sometimes we're going to have more of issues with language when they present. I think Dr. Soul and I are still in the process of working with a patient that we're kind of leaning towards a semantic variant of PPA. So they have some loss of word meaning, they have impaired object knowledge. They have fluent speech, but their speech is often like doesn't have much meaning behind it, as well as this kind of contrasts with the logopenic primary progressive aphasia. They might have these word finding pauses. They might have inability to repeat after you. And this actually most commonly has AD pathology, which can be confusing. So I wanted to make a key point here. So they could have an increase in both amyloid and tau in this particular variant, which would make things even more difficult. In that instance, you might want to kind of consider that FTG PET scan. That might kind of point to some changes as we kind of saw on that earlier slide. All right, now we have this slide on FTD. Bruce Willis was one of kind of the more famous patients that I think is kind of coming out in the open now. I think there's maybe some back and forth about is this PPA, is this FTD? But typically in FTD, their presentation, they're going to have some sort of behavioral changes, some early disinhibition. Sometimes that can be, compulsive gambling, sexual behaviors, things of that nature. They might pick up smoking, some hyperoralities, things like that. They're also going to have executive function that's going to be greater than their ability to have like pure memory recall. I kind of want to contrast that with AD, which you have more of this episodic memory, rapid forgetting, some of this spatial disorientation. I might ask them, if they go to Walmart or Costco, any sort of big box store, are they able to find their car afterwards? They might have word finding difficulties later, but behavioral symptoms again later. And again, with an MRI, you're going to have more of that medial temporal or temporal parietal atrophy, contrast with this frontal changes in this FTD. All right, dementia with Lewy bodies and Parkinson's disease dementia. Again, this is a completely different pathology. It's going to be your alpha-synuclein. You're going to be fluctuating cognition, early visual hallucinations, typically well-formed. Can have some REM sleep disordered behavior. Again, that's going to be the patient's bed partner saying they're flailing in their sleep, things of that nature. They could have some Parkinsonism as well earlier. But again, they're going to have more executive dysfunction rather than this pure memory recall. Here we have this Parkinson's disease dementia, visual spatial impairment, memory retrieval deficits. Do you guys remember what we might see on this FTG PET findings for these patients? Going to be decreased in. No, so that'd be for AD. For Parkinson's disease would be more occipital in the back. Again, we have some vascular cognitive impairment. It's going to be more of this classic, board question. They have like this stepwise cognitive decline. You could see on MRI, you could see, some lacunes, some microbleeds, some strategic infarcts that might kind of mimic some other vascular diseases you might see, particularly the thalamus, angular gyrus, caudate, enlarged periventricular spaces. This is again kind of showing that it can be quite variable in terms of their presentation. The temporal parietal most affected in AD, not as much here, kind of showing some more, not necessarily random, but areas that are more affected by the vascular insults themselves. All right, and everyone's favorite normal pressure hydrocephalus. Again, the clinical triad, the wacky and wobbly. This would be diagnosed using the colossal angle. is going to be more acute in patients due to this tinting of the ventricle, which can cause some of these cognitive changes. Anybody remember maybe from a test they recently took, what symptom improves first following a therapeutic LP? Yeah, so the gait. So good job. So you guys got one question right. Uh, but yeah, so that could be important to think about. And again, it's because of this tinting periventricular space. All right, so we just have a few brief review questions. All right. So using FTG PET, showing hypometabolism of which of the following regions is suggestive of dementia with Lewy body? Yeah, D. So the occipital cortex, and again, it's going to spare the posterior cingulate cortex. We can, use this question to also kind of teach us some of the other things as well. So frontal anterior temporal lobes, maybe FTD, bilateral temporal and parietal lobes, thinking more AD. Okay, the presence of which of the following features can help differentiate between behavioral variant Alzheimer's disease and behavioral variant FTD dementia? You guys think it's the age that the patient presents, the clinical symptoms, CSF biomarkers supporting AD, family history, or the response to acetylcholinesterase inhibitor therapy? Some B's and C's. Who thinks C? Yeah, let's go with C. Yeah, excellent. Some references and key papers. Yeah, I appreciate you guys' attention. Again, here's the CME code for those who came a little bit later. Did anyone have any questions? Yes, sir. Yeah, definitely. Yeah. So Dr. Friedland was just mentioning that here at University of Louisville, kind of in conjunction with the engineering department, the speed school, they're kind of using AI to take a look at different patients' MRIs and kind of look at atrophy that might be missed by even the most seasoned radiologists. So that's definitely an exciting point. Yeah, Dr. Friedland, do you have a follow-up point? Oh, Dr. Yes, sir. Yes, sir. Yeah, definitely. So Dr. Freeland was again mentioning, that we have patients that are healthy without any signs of cognitive changes that have the presence of amyloid. Is it possible that these amyloid plaques could serve another function? Or all amyloid plaques eventually become pathogenic? And I think that's definitely an area for future research and evaluation. I've heard even, is it possible that, as the brain atrophies and there's this loss of volume, could it have like a scaffolding effect? Is it always going to, kind of continue to cascade to the accumulation of these neurofibrillary tau tangles, which would eventually lead to the degeneration? It's something that definitely there's further investigation for. Even showing that sometimes we're able to effectively clear plaques, but it doesn't necessarily correlate with cognitive improvement. Again, that might be when these patients are being exposed to these therapies. I think that's kind of an area for future growth. But yes, there's definitely a lot of room for further research for sure. Good point. Yeah. Yeah. So the question was, how do we kind of implement the use of biomarkers here at University of Louisville? And optimally, obviously, this is an outpatient workup. Oftentimes we might get the occasional inpatient consult for dementia, but it's obviously best done again in the outpatient setting, one that kind of allows us to have opportune time with the patient and the patient's family to kind of explain exactly what we think is going on, what these tests are, what predictive power they have, what they'll be able to tell us, what they won't be able to tell us. And even having that conversation, I think, is incredibly important. In terms of what we typically do now, we do have access to serum testing, which is a Quest send-off. Um, uh, and I think Dr. Johnson and myself have a few patients that we've been able to order that on. Um, we haven't used the Lumen Pulse G. It's a separate test that we're using here at University of Louisville. I'm not sure, but yeah, Dr. Johnson told me we have access to FD PET. I personally haven't ordered FDD PET because again, that's it's usually more of those more complicated patients that we're able to kind of point one way or another. We typically are for sure using the serum-based biomarkers now. And yeah, they do that. Yeah, the hypometabolism. Yeah, so yeah, we do have access. Amyloid, yes. Tau, no. For different pets, yeah. Dr. Brown. That's a good question. I think that it's more like what your expectations are in terms of their level of decline. I think that that there is kind of some changes in terms of if there's a greater fall from they're a high functioning executive and now they can't make their own breakfast. That would kind of change your diagnoses versus if they were at a lower operating level to begin with when they first presented to you. I think that's particularly why that's important. I think that obviously different levels of education can be affected by Alzheimer's disease as well. It's not necessarily, people of lower education status would be more or less affected, but that's particularly why we asked that question. That's a good question. I think that some of the research is showing that the MIND diet, which is based on the Mediterranean diet, and sometimes we say what's good for the heart is good for the brain. Whether that's actually helping with Alzheimer's disease itself or more trying to eliminate some of these vascular risk factors for stroke and some of these other disorders, I think is particularly helpful. I think it's important to kind of remain in those social circles that's been protective as well. So kind of continue to go to some of these different groups, whether that be, a community group, some sort of social group, a church group, things like that are all been helpful. No one at U of L has used it, except for geriatric department. Yeah. And I think they have one or two patients. Yes, sir. That's a good question. I think that, kind of based on my own personal belief, I think there's a lot of kind of different interactions. One of the things that they were looking at in the past was, some of these different genes like ApoE 4. It's actually most common in Nigeria, but whenever we correct for some of these age-matched controls, they have less cases of AD than we do here. And so maybe that brings into diet, maybe some interactions with the biome of the gut could be playing a role. It's kind of difficult to say for sure, but we'll kind of try to tease that out in the coming years. I have seen that. I haven't read the literature on that to make an informed statement. Um, I'm not sure it could hurt, but I'm not sure how beneficial it is. Yeah, so exercise, like I said, what's good for the heart's good for the brain. All right. Any other questions? All right, I appreciate y'all.